Can I make a small comment? I see the dichotomy between what you guys want, senior endoscopists, you and your endoscopic team, versus what the surgeons here seem to think that the patients need. Obviously, academic points made, you need to do regular kind of endoscopy the way it's described, and you're trying to look for early lesions. The surgeons are bothered about the big lesions and where the endoscopist can fit in those scenarios. So they suggested EUS guided FNSCs of lymph nodes around where you want to. And there's another scenario which is rapidly coming up, which I don't know, you didn't touch upon, maybe your senior colleague would touch upon, would be post-neoadjuvant residual tumor assessment, which is becoming a very, very dominant scenario in the Indian context, wherein decision-making is becoming more and more difficult for the surgeons now, because patients do come and ask us, I'm all right, why do I need surgery? And now, at least, even in a small government hospital that I work in, patients do ask us, and patients do go back to the endoscopist from the surgeons, and endoscopists seem to be completely at sea as to what to do with those endoscopies. Because the way the SANO trial was figured, apparently endoscopists played a major role in determining whether there is a residual tumor or not. But your talk didn't touch upon that. I hope somebody along the way touches upon those areas.
Sir, pre-treatment staging I touched upon, and I didn't touch that. But it's a very important area, and often we need to rely on biopsies for the assessment of that lesion.
Pushing this point again, but it is not a simple biopsy. It is not just doing endoscopy and picking up a few mucosal pieces, because that does not pick up the tumor. And the surgeon is really afraid that is it a sampling error, or that you've truly done what the Dutch people have determined that this is what needs to be done to pick up the residual tumor in a way which the protocolized way endoscopy is done in those studies, the SANO trial. I don't know if you've been through those trials or not. And the surgeon is really afraid that I should not miss a tumor because my endoscopist doesn't know what to do. And then a few months down the line, patient is back with a residual tumor. Those are the reasons why surgeons operate, that I should not miss a residual tumor.
Good point. I would like to answer this question for my colleague. Just is sampling error. Good point. What is the size of the biopsy that you would like to take? First point. Number two is where you would like to take the sample. So when I was in the initial part of the training, I was talking about more than 2 decades ago. My colleague used to say, you have to, if it is most of the things that you see in India, you tend to get them as T3, T4 lesions because they got dysphagia. So for that, you just need to take at least 8 samples, as you rightly pointed, 7. So that should be not the small biopsy forceps, it's a bigger one. You need to see the chunks, and you should be able to take it from circumferential, not from the ulcerated area. Sampling error, yes, you're right. Number 2, we all got this NBI, where you can able to see where the dysplasia is, and you focus to take it from the biopsy. Number 3, especially taking biopsies from the food pipe can be really difficult. In this scenario, I teach my students what you do is you actually pull back this biopsy forceps with the open one right to the biopsy forceps, and you angle the scope so that you exactly go into where you want to go in, because it's parallel to you. So you want to make it perpendicular. The only way you do that is basically you get the biopsy forceps forward, you open the biopsy forceps, and then you get around it. But when you change the direction of the biopsy scope, you can directly hit where you really want to. So biopsy, yes, sampling error is possible anywhere, as we are in the same stage as the EUS. That has actually changed by using the NBIs onto it. Number 3 is washing that one, and when you have a bleeding points, then you need to observe that as well. So sampling can be avoided by using the combination techniques.